My name is Prax. Yes, that's fine. So, as I was saying, my name is Prax. I'm currently in F3 working on an oncology and hematology award. Some of you may remember me from the SBAs in hematology. Hopefully, you found that useful. Today, the topic is going to be oncology and palliative care situations, really the core stuff which comes up in medical school exams. We're not going to, delve into molecular pathways or any specific tumor sites, just the core stuff that you're expected to know during medical school. So the structure will be, I'm going to show a question, a classic sort of medical school question. You'll have about a minute to have a think. Emily will then put up a poll. You can all put in what you sort of would have answered anonymously. That gives me an indication of which questions or areas there are going to be misunderstandings. And then I'll explain how I analyze each vignette, and there's some general information about oncology and palliative care, which I'll go through, which is going to be useful for you. Okay, so let's jump straight into it. So this is question 1. I'll give you guys sort of, and some of these questions are going to be much longer than others, so I'll give you guys sort of 30 or 40 seconds for this one, and Emily will then put up the poll. Okay, so the first thing I always advise when performing single best answer questions is actually you shouldn't read the stem first. The first thing you should read is the question, okay? Because this will tell you what kind of question is being asked and it primes your mind to analyze the vignette from the start. This will save you time, but really it gives you more time to think about what the answer is going to be. The second thing I recommend is to not look at the answer options until you've had a thought and come up with a preliminary answer. Now, this is usually possible in most questions. Sometimes it won't be because you'll be given sort of, in some questions, you'll be given different options of what you could do. So it's not possible to come up with the answer. But that's my general advice for approaching any vignette. So let's analyze this one in particular. So the question is about genetic tests. So you already should think that this is a question about an inherited syndrome. Now, the main features of this vignette are going to be, first of all, the age of onset for all of the affected individuals. So in the vignette, we've got a 28-year-old man with altered bowel habit and rectal bleeding. We've got his father, who passed away from bowel cancer, specifically at the age of 48. This is very young. And a paternal grandmother that died very young, and his brother, who you would assume is also either in their 20s, 30s, or 40s with similar symptoms. So we've got multiple people within a family likely presenting with symptoms of a cancer. And the second thing to think about is what is the apparent inheritance pattern in this vignette? So all 3 generations or consecutive generations are affected. Okay, so we've got a grandparent, we've got the father, and we've got the patient and his sibling. So that suggests a dominant inheritance pattern. And we've got sort of a grandmother and also a number of male affected individuals. So both sexes affected. So in general, you would think that this is an autosomal dominant like inheritance pattern. And then finally, to figure out which inherited syndrome it is, you need to know the tumor sites that are being affected. So the presenting individual, rectal bleeding, altered bowel habit, suggests colorectal cancer. You know the father it says bowel cancer, and when we say bowel cancer, we generally mean colorectal rather than small bowel or upper GI. The paternal grandmother, it's not specified, but they've had a gynecological cancer. And the brother has similar symptoms, altered bowel habit and rectal bleeding. So the main combination here is colorectal and gynecological. And there are only a few inherited syndromes which have that predilection. So now we can look at the answer choices, and you can see that what we're testing for is sort of different mutations. So let's have a look at what you guys thought. Okay, so the most common answer is the correct one, B, and then I think you're evenly split across the others. So let's go through each of the individual mutations. So, and we're going to go through these in a bit more detail as well. So the correct answer B is MLH and MSH. These are mutations commonly seen in hereditary non-polyposis colorectal cancer, otherwise known as Lynch syndrome. And then the other tumor site that's commonly affected is the endometrium. So, it fits with this history. Okay, and it is inherited in an apparent autosomal dominant pattern. And just so you can be clear for the future similar questions, we'll go through all the other incorrect answers. So option A, BCR-ABL, is a fusion gene commonly seen in most cases of chronic myeloid leukemia and also a fraction of ALL and AML as well. The RB gene mutation, the RB stands for retinoblastoma gene. Okay, that's most commonly presenting as a pediatric eye tumor. The RET gene for option D is seen in multiple endocrine neoplasias, particularly type 2 and type B. And then finally, BRCA1 gene mutations, most commonly seen in breast cancer and ovarian cancer, and then smaller amounts in pancreatic and prostate. So just a general point about genetics and cancer. This is a simplification, but in general, the genes related to carcinogenesis can be thought of in two major buckets. You've got the tumor suppressor genes, which encode for proteins that in some way are involved in regulating or suppressing cellular proliferation or growth. Okay, a very common one, the P53 gene, sometimes called sort of the guardian of the genome. It's activated when there's damage to DNA. 50% of cancers have mutations in this gene. It's not necessarily the case that it's the driver mutation, but it is certainly very common. And the important thing to remember about tumor suppressor genes is that you have two alleles, and in general, having one allele is sufficient for the tumor suppressor protein to have its effect in suppressing the carcinogenesis. And so really you need biallelic tumor suppressor gene function to be affected for cancers to develop. Now, because of this, generally with tumor suppressor gene mutations, if you have a single hit or one allele affected, the second allele can get mutated, but at some point during life. And this is usually after the time where most people are going to be childbearing. And so the single allele is very commonly passed on from one generation to another generation. But because the lifetime risk of getting the second hit is very high, the way it's inherited is it appears to be an autosomal dominant inheritance pattern. Okay, so you inherit one and then you get the second one de novo or sporadically in a given individual. So that's tumor suppressor genes. Proto-oncogenes refer to genes which encode proteins that in some way promote cellular proliferation or growth. And these are normal genes. Okay, we need these in several periods of our life. So embryogenesis, during childhood, and even in adulthood when we need to regenerate and repair given tissues. In general, you only require one hit or one allele of a proto-oncogene to be affected to generate cancer, because if you have a mutated proto-oncogene whose expression is not regulated by normal negative feedback loops, or the protein which is affected has properties which mean it doesn't respond to negative feedback signals, the normal version of that gene or protein is not going to be able to influence the abnormal one. And hence you only need a single hit for cancer to develop. And because of this, these are not really inherited in any given particular pattern. They arise de novo or sporadically in individuals, typically as adults. So that was a couple of broad points about genetics and cancer. These are the conditions that we're going to go through in a little bit more detail. So the first one, a chromosomal translocation between chromosome 9 and 22, creating the fusion gene BCR-ABL1. You may have heard of the colloquial term, the Philadelphia chromosome. Now, where does this come from? When you have the translocation between chromosome 9 and 22, the result is the normal chromosome 9 looks a little bit bigger and chromosome 22 looks very, very small. And you can see this when you do cytogenetic tests such as karyotyping. Okay, that's when They have cells, they get them into metaphase, you can see all the chromosomes, and then they take pictures. Okay, so you can see a very small chromosome 22, and that is actually what the Philadelphia chromosome is. Philadelphia because it was discovered in Pennsylvania, and the capital of which is Philadelphia. Okay, so that's the translocation, that's where the terminology comes from. Let's talk about the genes involved in a little bit more detail. So ABL1, that's the gene on chromosome 9. It codes for an intracellular tyrosine kinase. Okay, so this is a type of enzyme which phosphorylates and activates other proteins. And in general, they are involved in promoting pathways related to cellular proliferation and growth. Okay, and like anything which promotes proliferation and growth, we have a number of negative feedback mechanisms to control either the gene expression or the protein function. Okay, so that's normally under tight control. BCR is a gene, stands for breakpoint cluster region, on chromosome 22. We don't actually fully understand its function within sort of normal physiology, but what we do know about it is that it is constitutively expressed, which means that area of the genome is pretty much what that, meaning it's not sort of wound up and silenced. And transcription factors are always stimulating that part of the genome and that gene. And so the expression of BCR is not really affected by negative feedback loops in the same way or intensity that ABL1 will be. So why is this important? When you get the translocation between 9 and 22, the promoter region for the fusion gene is for BCR, meaning that the fusion gene itself is constitutively expressed. The protein it produces, which is BCR-ABL, retains the tyrosine kinase activity, and therefore what you get is a tyrosine kinase which doesn't respond to negative feedback loops. Okay, so you get this sustained proliferative and cell growth signal. Okay, hopefully that bit of physiology was clear. If you have any questions, please put it in the chat and I can address it at the end. This translocation is most commonly observed in chronic myeloid leukemia. It's responsible for well over 90 to 95% of cases. And it's also observed in a fraction of acute myeloid and acute lymphoid leukemia, although in those conditions, it's really a prognostic genetic marker rather than the main pathophysiological driver. And these mutations, the translocation arises de novo. Okay, so if you have a parent or a sibling with chronic myeloid leukemia, you're not more likely in any way to develop the condition yourself. So that was CML. Let's move on to hereditary non-polyposis colorectal cancer, otherwise known as Lynch syndrome. So this is a syndrome where there are mutations in specific genes which encode DNA mismatch repair proteins. I've listed probably the four most common mutations, the most common genes in which the mutations are there. It's debatable whether it's worth sort of memorizing them, maybe like the day before your exam, because I certainly had one in my finals where it asked what is the, which of the following mutations is seen in Lynch syndrome. So these are the four most common. It produces a very high lifetime risk of cancer. So if you imagine you inherit one sort of mutated allele for a DNA mismatch repair gene, and you obtain the second hit during your lifetime, you are then likely to accrue or accumulate a number of DNA mismatches within any particular part of the genome. And then over time, the accumulation of those errors will eventually drive carcinogenesis. The most common tissues which are affected by this syndrome are colorectal and endometrial. And we observe sort of smaller numbers in other tissues, some of which I've listed there. So DNA mismatch repair proteins are effectively like tumor suppressor genes. And so as we discussed before, tumor suppressor genes, the apparent inheritance pattern is autosomal dominant. Okay, so you inherit one mutant allele and you generally obtain de novo the second allele hit during lifetime. And both the GI mucosa and the endometrial lining, these are constantly proliferating and regenerating, and so therefore there is a lot of DNA replication and opportunity for errors to arise. Now, if you do have a young patient presenting with colorectal cancer and endometrial cancer, this is the condition that you need to be thinking of. okay? And asking a detailed family history is really important in those cases. And if you do get someone who is on a genetic test positive for Lynch syndrome, you should offer genetic testing to first degree relatives, and they can opt for regular surveillance. So for example, colonoscopy at an earlier time or colposcopy at an earlier time. Just a quick answer for Sophie. The slides in the recording, I'm not sure about the slides, the recording is usually on YouTube, and it should be accessible to anybody who is attending now. Okay, so that is for HNPCC. Next one, retinoblastoma. So this is a rare pediatric eye cancer which results from a mutation in the RB1 gene. This normally encodes for a protein which regulates the transition of the cell cycle from G1 to S phase. So the S phase is the synthesis phase where cells will synthesize lots and lots of protein and replicate their DNA in preparation for cell division. Again, this is a tumor suppressor gene, and so the apparent inheritance pattern is autosomal dominant. You inherit one hit, you get the second de novo during your life. Sometimes that de novo one can happen very early in a phase where you're replicating a lot, such as embryogenesis or in childhood, and that's why we see some of these childhood tumors. Same thing for all tumor suppressed genes. If you confirm it with genetic tests, you should screen anybody else, first degree relatives, and offer them the appropriate surveillance. Next syndrome, multiple endocrine neoplasias. This one, honestly, for some reason is really common on medical exams, and there is no real interesting or fun or good way to remember these syndromes. I have always just memorized them sort of like a few days before the exam. And the things that you need to remember are the gene involved. So MEN type 1 is MEN1 gene, which is useful and simple. And for MEN type 2 and B, it's the RET gene. There are different tumor sites affected. Honestly, this is just, you just need to memorize this. If anybody has some good acronyms or, mnemonics, please let me know. And it's the same, all of these are tumor suppressor genes, and so genetic screening and a good family history are essential. Okay, next one is BRCA. So BRCA 1 and 2 are both genes that encode for a different set of DNA repair machinery. So when we talked about Lynch syndrome before, it was specifically DNA mismatch repair. BRCA 1 and 2 are typically for single-strand DNA breaks. Oops. Okay, so again, you inherit one hit, you likely get the de novo hit during life. There's a very high lifetime risk of cancer. For BRCA, it's typically breast cancer is the primary tissue, and the second most common is ovarian. There are smaller numbers of pancreatic and prostate observed. Same thing, another tumor suppressor gene. The apparent pattern of inheritance is autosomal dominant. And for this case, any carriers may opt for prophylactic mastectomy and bilateral oophorectomy as well. Okay, so that was all of the genetic syndromes and cancer that we're going to cover for today. So now we're going to move on. Have a look at this question. We'll give you 30 to 40 seconds to have a think, and then the poll is up for you to have a go. Okay, so this is a fairly short one. So again, the first thing you should do for any vignette is read the question. So this is specifically talking about an agent which is responsible for symptoms. Okay, so this is a side effect or an adverse effect of a drug. Within the vignette, what you have is a lady with breast and ovarian cancer. Okay, she's had a primary therapy, which is radical surgery. So double mastectomy. Radical hysterectomy means total abdominal, as well as both of your ovaries, so bilateral, and fallopian tubes, bilateral salpingo oophorectomy. Okay, the surgery sort of cause of her new symptoms. Okay, so her new symptoms are pins and needles in the feet. That is a type of paresthesia. Okay, so a neuropathy. Other forms of neuropathy can be numbness, tingling sensation, burning, pain. And we can see in the vignette that she's received adjuvant chemotherapy. So just a small note on what adjuvant chemotherapy is. It's typically chemotherapy done after a primary therapy. Okay, so the primary therapy is something that you do where you intend to cure someone. So radical surgery, and you can also have radical radiotherapy. Now, this will the primary therapy aims to get rid of all visible, measurable disease burden. And this generally is not curative. We all often see patients recur with new metastatic deposits. And this is because we imagine that there is some form of micrometastatic disease that we're unable to measure in most solid cancers. Okay, so for patients who are suitable for a primary radical therapy, whether it's surgery or radiotherapy, is often given is a adjuvant or postoperative or post radiotherapy systemic therapy, and this is usually chemotherapy to try and clear out the micrometastatic disease. Okay, so the aim here is to reduce the risk of recurrence of cancer. Okay, now there are loads of chemotherapy drugs, and I'm just on the slide. You don't have to remember all of these, but I'm just illustrating that there are two major sort of categories of medical therapy or chemotherapy. There are the cytotoxic agents, meaning they kill cells. So cyto is cells, toxic, kill. There are 5 broad classes. They all act on DNA in some way, and therefore are only really effective when cells are in the phase of the cell cycle where the DNA is exposed. Okay, so they have to be actively dividing or synthesizing DNA. And you've got these 5 agents that have different mechanisms. We won't go through that today, but this is going to be important for predicting the side effects of your drugs later on. Then there's also a bucket of medical therapies which are non-cytotoxic, meaning they don't actively work on actively dividing or DNA replicating cells. They work in a different way. Most commonly, we have sort of hormone therapies common in breast cancer, prostate cancer, targeted therapies, which usually are given for people with specific mutations, for example, tyrosine kinase mutations or EGFR mutations. And then in the last maybe 10 years, we've had the advent of immunotherapy, of which there are a few different types, where we're trying to modulate the immune system to increase its ability to clear populations of cancer cells. So the question, we'll come to the answer in a moment, but is about cytotoxic chemotherapy, okay? So chemotherapeutic drugs have no ability to distinguish between healthy dividing and replicating cell versus cancer. And so any healthy tissue which is actively proliferating is going to be susceptible to the effects of cytotoxic drugs. So the bone marrow, very commonly, you can have pancytopenia, so anemia, thrombocytopenia, and neutropenia, which can result in an immunodeficiency. The GI mucosa, which sort of replicates or regenerates top to bottom every 28 days, can be affected. This can manifest as mucositis or diarrhea. The skin and hair follicles, which can manifest as rash or hair loss, and then the gonadal population of cells, which can result in infertility. So those are the cytotoxic side effects of chemotherapy. And there are also side effects which are related to the direct molecular toxicity of either a chemotherapy agent or its metabolites. Okay, so many chemotherapies affect the chemoreceptive trigger zone within the central nervous system, and therefore result in really difficult and intractable nausea and vomiting. Most patients who are on chemotherapy will get prophylactic and multimodal antiemetic therapy. They can also be toxic to neurons, and they cause a peripheral neuropathy or a length-dependent neuropathy. It's important to try and remember why certain types of neuropathy are the way they are. If you remember how neurons are structured, particularly in the peripheral nervous system, the cell body is within the spinal cord or near the spinal cord, and the axon is very long, all the way to the skin or whatever the innervation is going to be. And if a chemotherapy drug is toxic to the neuron, it can damage it anywhere along that axon. But if you remember from physiology, neurons can only repair if they have the adequate nutrients and proteins delivered via the channels that are within the axon, and all of those nutrients will come from the cell body. Okay, so if you have something which is sort of non-specifically toxic to a neuron, the ends of the neuron get affected first because they are the furthest away from the cell body, in the same way that when you have ischemia to any given tissue, the tissue which is furthest away from the vasculature will die first. Hopefully that was clear. And many chemotherapy drugs are just directly toxic to the liver because the liver metabolizes a lot of these, and the metabolites can be toxic. And the same is true of the kidneys. Either the kidneys are metabolizing the chemotherapy, or the metabolites are toxic, or they're trying to excrete and are struggling to do so. So there is a list of very classical chemotherapy and side effect pairings that, again, you're probably just going to have to memorize at some point. And in the question, I know we're doing a lot of sort of general knowledge conveyance here, but the question had peripheral neuropathy, and platinum-based chemotherapy drugs such as cisplatin or carboplatin are the ones which classically cause peripheral neuropathy. The other ones are vinca alkaloids like vincristine. And then we've got a list of other classical pairings. So cardiomyopathy, or sort of global cardiomyopathy, very commonly seen with anthracyclines like doxorubicin and Herceptin. Just to note, Herceptin is actually a brand name. The drug name that you'll probably see on exams is trastuzumab. Another one, hemorrhagic cystitis, very classically associated with cyclophosphamide. Cyclophosphamide, when it's metabolized, it results in a metabolite which is irritant to the bladder lining, and that causes damage and therefore the hematuria. In order to mitigate this, lots of patients who receive cyclophosphamide as part of their chemotherapy will get, number one, lots of intravenous fluid hydration, and also a molecular binder of the metabolite of cyclophosphamide called mesna, MESNA. And also what they'll have is monitoring for hematuria. So they'll have, particularly at the start of their chemotherapy regimen, BD urine dipstick to look for microscopic hematuria, so they know if that toxicity is happening. Endometrial cancer, quite commonly seen in those who have tamoxifen. Now, endometrial cancer in general occurs when there's unopposed action of estrogen on the endometrial lining. So tamoxifen is a selective estrogen receptor modulator. So if any woman has already gone through menopause, and so their ovaries are not secreting estrogen, and therefore they're not ovulating, this is really important because if you don't ovulate, you will never have a corpus luteum during your menstrual cycle, and therefore your progesterone levels will never really be the same as a woman who is still having active menstrual cycles. So in postmenopausal women, we never give tamoxifen because that would be unopposed estrogen activity on the endometrial lining. Instead, the way we sort of modulate estrogen is by using aromatase inhibitors, okay, like anastrozole or letrozole. The next one, lung fibrosis, very, very commonly seen with a drug called bleomycin. And if you do get lung fibrosis, one thing we see is that if those patients are readmitted, we're very careful to give them unnecessary oxygen. Okay, so oxygen itself, is good, but giving everybody high flow oxygen isn't necessarily good because we know oxygen itself, it produces radicals, creates oxidative stress within a cell. And if somebody's previously had bleomycin, often, and you're worried about their sort of lung function, often will have lower target sats, 88 to 92. We won't over-oxygenate them because the oxygen itself can make the fibrosis worse. And then finally, ototoxicity. This is very common with a platinum-based chemotherapy drug, cisplatin. Okay, so those are some classic pairings that you can remember. And the question itself, sorry, I should have put this earlier on before all the explanation, was D. Looks like most of you got it, which is great. And it's just one of those things you're going to have to remember. And we've been through the explanation of the other ones, so great. Okay, have a look at this one. Oh, let's analyze this one. So again, first thing, read the question. This is about investigations, okay? And remember that whenever you order an investigation, the ultimate goal is there a treatment I can give this person? Okay, that's what we do in medicine. In most cases, we're looking for ways to treat any given medical condition. And the way investigations allow us to do this is either by making a diagnosis, identifying a complication, or telling us that their baseline function is okay for a given intervention. So for example, you might want to diagnose pneumonia with a chest x-ray, versus if you want to plan a surgery, you need to know that somebody's hemoglobin, their platelets, their clotting is normal. Okay, so kind of two ends of the spectrum as to why you want to do investigations, but it's always to guide your choice of intervention. So now going on to the vignette, the first thing that you need to know is the setting and the chronicity of the history, okay? So they're attending their GP and they've had 2 separate episodes, okay? So first of all, we know that getting a GP appointment is not an immediate thing. So immediately you know that this history is over several weeks and they are clinically well enough to go to their GP instead of their emergency department, okay? Even on examination, you know that they're very, very clinically well, there's no oxygen requirement, they're hemodynamically stable, and they're not pyrexial. The main symptoms are blood-stained sputum, okay, or hemoptysis, and progressive breathlessness, and they have got risk factors for lung cancer, which are the background of a 20 cigarettes per day smoking history. It's not given how long, but that is a big risk factor, and also the age of 60. So the question is, what is the most appropriate investigation? So the answer in this situation is D. I don't know if Emily can put up the poll just to see what everybody thought. Great, so most of you are on the right track. And the reason the X-ray is the most important is because from the history and the examination, we don't have a diagnosis, okay? So the aim is to diagnose what's going on. So let's just go through the individual options and why they're not correct. So the first one, sputum culture and sensitivity. There are no symptoms or signs at the moment which suggest an acute infection, okay? And if you don't suspect an acute infection, you shouldn't send anything for a culture, okay? Because cultures can be positive due to contamination or lab errors, etc. So unless you're suspecting an infection, you shouldn't send a blood culture. The other important reason that's the case is your history and examination should tell you roughly where the infection is. And then depending on the source of infection, you can predict which bugs are going to be affected. So for example, if you have a urine infection versus a chest infection, you expect to find E. pneumo in the chest. So when you send sputum or blood cultures and you get a positive result, you can kind of deduce whether it's true or not based on where your infection source is likely to be. The second option, B, CT chest, abdomen, and pelvis, this is a classic oncology investigation, but for staging, meaning we want to know how large a tumor is, which lymph nodes are affected, and are there sites of metastasis. It's generally not the first line investigation for anything, okay? And the only other indication is if you have evidence of metastatic disease and you're not sure what the primary is, okay? So that's what this acronym CUP is, cancer of unknown primary. Option C, spirometry testing, is useful in the workup for patients with lung cancer, which is the most likely diagnosis in this vignette. And the reason it's useful is because some lung cancers are amenable to surgical resection, okay? But in general, you need to have at least 1 liter of forced expiratory volume to be able to survive, basically. So the 2 sort of surgical options in broad terms are pneumonectomy and lobectomy. So in general, the targets are if you have more than 2 liters of FEV, you could theoretically have a pneumonectomy. If you had more than 1.5 liters of FEV, you could have a lobectomy. But we save this isn't sort of part of the diagnostics, this is part of surgical pre-evaluation. And then option D, this is simple, you're in the GP, you can request this, and it's the most likely to show a primary lung cancer, which then will inform your further investigations. And then option E, sputum cytology. This may be useful for sort of histological assessment of a cancer in general, but we prefer bronchoscopic-led biopsies, and where you can see the architecture of the tumor as well. And so just briefly on lung cancer, the main symptoms, we can split them into direct lung compromise, such as cough, hemoptysis, shortness of breath, and chest pain. It's usually pleuritic chest pain, and the metabolic effects of the cancer, so weight loss, loss of appetite, and fatigue. On examination, you would expect really only in later stage cancers to have a focus of dull percussion notes and reduced breath sounds. You may observe cachexia, which is sort of emaciation or sort of loss of muscle mass. Finger clubbing, this is a classical sign you see in small cell lung cancers. The official term is hypertrophic pulmonary osteoarthropathy. It's a kind of paraneoplastic syndrome. You may identify lymphadenopathy, so in your respiratory examination, which I'm sure you will learn, you should be evaluating the cervical lymph nodes and the right supraclavicular node. And then on bloods, all cancers tend to produce a chronic low-grade inflammation. We know that when there is inflammation, you're slightly more coagulable, and this recruits platelets, and this is why in some patients you will see a non-specific thrombocytosis. And this is the sort of order of investigations that we'd go: chest X-ray to find the primary mass. Bloods, in general, bloods are to see sort of baseline function, so for fitness for chemotherapy, but also you can find sites of metastases. For example, if you had deranged LFTs, you might be concerned about liver metastases. The CT, chest abdo-pelvis, is for staging. Cytology and bronchoscopy plus minus biopsy is for laboratory diagnosis. And then the lung function test that we mentioned as part of surgical pre-evaluation. Okay, question 4. Oh, we've got some questions as well in the chat. Same question, a recording should be available afterwards. Okay, so let's get the poll up. You guys can have a go. So let's go through this one. So again, the question is, what is the likely oncological complication to account for the symptoms? So let's have a look at the vignette. First of all, they're in respiratory distress. Okay, that's important to note. But what gives you the answer is the other symptoms. So they've got facial and neck swelling. Okay, this tells you there's inadequate venous drainage of the head and neck. The word plethoric, it's one of these sort of ancient lingo terms in medicine, but it refers to the reddish brown complexion that you can see sometimes in the skin when there's dilatation of cutaneous capillaries. Okay, so it's another sign suggesting inadequate venous drainage of a system. And this is further confirmed by the external jugular vein being prominent and engorged. Okay, and the external jugular, of course, feeds into the superior vena cava. So the concern is that this is superior vena cava obstruction. So that is the correct answer, the triad of hypoxia and associated breathlessness, facial edema, and jugular bulge. Oh, perfect. You all got that one. Excellent. Just quickly, we'll run through the symptoms of the other options. So metastatic spinal cord compression, what you're looking for is lower back pain, lower limb neurology, and urinary or bowel symptoms. Okay, and if it's compression of the spinal cord itself, you will get mixed motor neuron signs. So lower motor neuron signs at the level of compression, and then upper motor neuron signs below the level of compression. And that's usually for cervical or thoracic metastatic disease. The spinal cord itself ends at L1 at the conus medullaris, and below that you've got the cauda equina, which contains the nerve roots of all the lumbar vertebrae and the sacral vertebrae. Okay, and the cauda equina is purely the nerve roots, so they contain lower motor neurons. So you'll get pure lower motor neuron signs on your examination. Okay, so if you have lumbar or sacral metastatic disease, you expect only lower motor neuron signs. And the bowel and bladder sphincter function is controlled by nerves coming from the sacral plexus, S2 to 4. So if you have either spinal cord compression or cauda equina syndrome, you run the risk of being either incontinent of urine or feces or the opposite, so urinary retention and fecal retention. Anaphylaxis, I'm sure you all know, presents with stridor, facial edema, and urticarial rash. Pulmonary embolism would have been a good differential for this case. They're hypoxic, they're tachypneic. They will probably be tachycardic if you measured it, but it doesn't fit with the facial edema or engorged external jugular. And then SIADH is another common complication of cancer. It's a paraneoplastic syndrome, but the main presenting features are fluid retention and confusion. Okay, so we've kind of gone through this already. Just the signs of superior vena cava obstruction. The most common tumors that cause this are lung cancers, head and neck cancers, and lymphoma. And the other differential, instead of sort of tumor causing obstruction, some patients without cancer can have the same condition if there is a large blood clot in the SVC. So anybody with a thrombophilia is at risk, albeit unlikely, of this condition. So we've gone through the signs and symptoms, so inadequate head and neck drainage, respiratory compromise. The reason you get respiratory compromise is the SVC drains into the right atrium, and then the right side of the heart pumps blood to the pulmonary vasculature for oxygenation. Okay, so if you're not draining the head and neck particularly well, you've got less volume of blood being oxygenated by the lungs, and so relatively speaking, you will not, you will be hypoxic, and therefore you'll be tachypneic. The esophagus can be compressed, particularly by head and neck tumors, which are causing SVCO. So some patients may present with dysphagia, and some even with stridor if the trachea is also being compressed. So we'll just talk about a few other common complications of cancer. So SIADH, as I said, is a paraneoplastic syndrome. It's most common in small cell lung cancers. The small cells themselves are actually neuroendocrine cells, so they are normally secreting small levels of hormones, and when those cells become malignant, you tend to get an excess of those hormones. So what you will see in these patients is ectopic ADH secretion. ADH acts on the collecting duct cells and upregulates the expression of aquaporin channels within the collecting duct. So you will be more likely to have water flow from the urine within the collecting duct back into the medulla of the nephron. So you preferentially retain water rather instead of sodium. So you get a dilutional hyponatremia. And like all causes of hyponatremia, it presents with nausea, vomiting, confusion, hallucinations, seizures, and in serious cases, coma. Okay, question 5. Have a quick read. Got some questions. Somebody in the audience is asking, is this euvolemic or hypovolemic hyponatremia? Yeah, it's a great question. It will be euvolemic hyponatremia. Okay. And just you might ask why is it going to be euvolemic? Yeah, fair, of course, I thought so. So in SIADH, the problem, the aberration from physiology is related to ADH function, which is involved in how much water you retain. Okay, but the overall fluid balance is going to be regulated by another thing, okay, and that's going to be blood pressure. So if you retain lots and lots of fluid, your blood pressure will go up, your blood vessels will be stretched, and you will have the secondary physiologic reflex, which is to secrete less angiotensin. Okay, that's the renin, angiotensin, aldosterone axis. So you'll have less angiotensin, less aldosterone, okay, and so you will not retain as much fluid. Okay, so the aberration in physiology is you tend to retain more water than normal, but for your overall fluid balance, that is going to supersede the ADH. Okay, so apologies. So that's question 5. Let's see what you guys thought. Great. So most of you are on the right track. So let's have a look at the vignette. So this is about a complication of breast cancer. Okay, so first of all to note is we already have a patient with metastatic disease. And if you have such patients, anytime they have an acute deterioration and are admitted to hospital, one question that should always be on your mind is, could this be due to progression or a new site of metastasis? So this lady is undergoing hormonal therapy with tamoxifen, and she's attending with a few things. So first of all, new back pain. Anybody with metastatic cancer with new back pain, you assume metastatic cord compression until you've proven otherwise. Obviously, it's going to be more likely if there are already known spinal metastases. But you can't take chances. You will put these people on flat bed rest, give them steroids, order an urgent MRI whole spine to be done within 24 hours. And only once you've excluded cord compression and you know their spine is stable, will you allow them to sort of move around the ward again. The other thing she's presented with is falls, okay? And this is quite common in the history where patients will not report subtle changes in lower limb strength, but they will fall or trip. And so this is an indication that maybe there's some underlying lower limb weakness or even altered sensation. If you can't feel the floor whilst you're walking, it is surprisingly easy to trip up. So this is an indication for you to do a detailed lower limb neurology exam. And then the final thing is she's presented with lower abdominal pain, visible distension on examination, and suprapubic tenderness, all of which point to urinary retention. And as I mentioned before, this is a very common complication of cord compression. When you compress the cord, the nerves that arise from the sacral plexus and control the function of the urinary sphincters can be affected, and it can go either way, either incontinence or retention. So the answer is, of course, spinal cord compression. So this is a medical emergency. We are very, very careful with these patients, okay? If they walk in, we want to be able to make sure they walk out, okay? That's the mantra in oncology. The cancers which commonly metastasize to the bone, I just remember the acronym PBR because it's part of medical education, so prostate, breast, and lung, and then two other common ones are thyroid and kidney. Typically, they present with back pain. This is often multi-level. If there are multiple sites of disease, it's exacerbated by movement or Valsalva. And because it's related to the activity of the cancer, they can also be present at night, even when lying down. Okay, so that's quite classical cancer pain. And thoracic back pain as well. Very few things cause thoracic back pain. So important to keep cancer in the differentials there. We've talked about leg weakness. They may report that directly, or you might find it in the history in the form of trips or falls. Sensory changes, usually patients don't report sensory changes, so this is something that you elicit on examination. And then urinary and bowel dysfunction, again, either incontinence or retention. And as I mentioned, the main stay of treatment is flat bed rest, spinal precautions. You will catheterize if they're in retention. You'll give them VTE prophylaxis because you're going to immobilize them. You give them high-dose dexamethasone. And the reason is around any cancer, there is a degree of inflammation and therefore edema. You give the steroids and acutely that what's called peri-tumor edema will lessen. And hopefully that will reduce the amount of compression on whatever is being compressed. In this case, it's the spinal cord. Because you give high-dose steroids, you tend to do blood glucose monitoring, and you get them the urgent MRI spine within 24 hours. Okay, and that when you do the MRI spine, you ask two questions. So, cancer within the body of a vertebra can result in instability and risk of sort of vertebral collapse. So you ask radiologists if the spine is stable, and of course, if it's so advanced that it's infiltrating the spinal canal, you ask, is the spinal cord compressed as well? Okay, and these questions are really important, and there are a number of scoring systems which help us decide what the most appropriate therapy is, whether they're suitable for surgical decompression with neurosurgery, or if external beam radiotherapy is useful, or if actually just palliative measures and sort of symptom control is appropriate. So that was the answer, spinal cord compression. Let's just go through some of the incorrect answers. So liver failure, you'd expect signs of encephalopathy, so things like confusion, hematemesis, ascites. Same with renal failure. You're looking here for signs of fluid overload, uremia, metabolic acidosis, SVCO we've been through, and UTIs. I hope none of you put UTI, because it's of course going to present not just with a painful suprapubic area, but polyuria, turbid urine, etc. Some question in the chat. Oh, that's a feedback form. Okay, question 6. So the last question, the 3 questions are a little bit quicker. Well, the questions are longer, but there's less explanation. So have a read. We're in the sort of prescribing section of this tutorial. Okay, so this is about medication changes, and from the question, I'm sure it's clear to you that this is a palliative care setting. So let's have a look. What did you guys think? Emily, could you flash up the answer of the poll? Okay, great. So you guys are on the right track. So option C, hyoscine butyl bromide. So let's have a look at the vignette in a bit more detail. So this person is at the end of life. We're focused on symptom control, and the main symptoms are pain and anxiety, and that's reflected in his syringe driver. Okay, so the morphine sulfate is for pain, midazolam for anxiety or agitation. What's new is he's got a oral secretion load. Okay, in general, when this starts, conservative measures are always best in the first instance. So if patients are able to sit upright, if they're able to tolerate suction by the nursing staff, this is what you do. But it's clear here that this is the secretion load is too much, despite regular suction. He's not in any more pain than normal. So the new medication that you need to prescribe is an anticholinergic. Okay, so respiratory secretions are largely driven by parasympathetic activity. Hormone for parasympathetic action is acetylcholine. So anticholinergics like hyoscine butyl bromide or glycopyrronium are going to be the drugs of choice. I'll just emphasize the sitting upright and the suction is really important, especially if patients are alert, because long-term use of and frequent use of hyoscine or glycopyrronium, yes, it will clear secretion loads, but there is also a risk that you can make their respiratory airways really, really dry. Okay, and so if somebody's alert, you want to try those conservative measures instead of running the risk of actually giving them just a different symptom to deal with, which is very dry airways, and that can be very uncomfortable for patients. So let's go through some of the other options. So metoclopramide is an antiemetic, which has some prokinetic effects. Haloperidol is usually for agitation, does have some good antiemetic effects as well, particularly at the end of life. Midazolam, generally for agitation, can also calm breathlessness, which is related to agitation. And then morphine, typically for pain, but also for pain-related breathlessness. These are the main end-of-life symptoms that you're going to encounter with patients in the palliative care setting. So let's just go through some of them. This is just a general framework for approaching palliative care. So always start with non-pharmacological first. Remember that your focus is comfort, quality of life, symptom control. So finding ways to hydrate and nourish patients in a way which isn't invasive is important. Regular washes. Some patients, if they're unable to move or control their bladder, will have catheters. Side rooms are, just humane. And having early conversations about ceilings of care, prognosis, and potential discharge destinations like nursing homes or hospices are really important. And patients and families really appreciate this because it's hard to understand medical information and process it quickly. So doing these things early allows patients and their family to process, ask questions, and then accept that their loved one is at the end of life. So we've talked a little bit about pain. Cancer pain is very, very common. Opiates are very good in general terms for cancer-related pain. The other thing which is quite good is steroids. So if you have liver-related metastatic pain or bone pain, steroids can be useful. In general, morphine and diamorphine are used. Oxycodone is slightly more renal friendly, doesn't accumulate as much if you have a renal impairment, and fentanyl more so. Fentanyl as well can be given as a patch, which is much easier and to administer, and also provides sort of a low dose, which is at a steady level, rather than having peaks and troughs with sort of PRN drugs. And when we get to the last few days or the last week, in general, subcutaneous administration is easier for everybody. Lots of cancer patients at the end of life struggle with swallowing, don't have an appetite, are struggling with nausea or vomiting. So subcut preparations are much better. And in general, you can provide 24-hour subcutaneous administration via a syringe driver. So nausea and vomiting, very common. I've just highlighted in green the most common reasons. So chemotherapy, as we discussed earlier, raised intracranial pressure, for example, from brain metastases, gastric outlet obstruction, and just in general bowel obstruction. These are all different mechanisms that produce nausea and vomiting. And this is really important because it will guide the choice of your therapy. So again, I hope you will have access to the slides of the recording later. This table is just showing you the cause of the nausea and the most appropriate drug, because it is targeting the relevant emesis pathway. Okay, so have a look at this. I haven't got time to sort of delve into each of the mechanisms, but this is important. Anxiety and agitation, again, very common. Midazolam is our go-to, has an effect on calming breathing as well. Levomepromazine and haloperidol are antipsychotics. Levomepromazine is sedating. Haloperidol has also some antiemetic effects. And then for respiratory secretions, which is actually the focus of the question, hyoscine, either hydrobromide or butylbromide, and glycopyrronium. These are all anticholinergics and therefore reduce respiratory secretion load. But like I said, if they can tolerate it, sitting them semi-upright, getting some oral suction is better in the first instance, so that you don't run the risk of having the airways become really, really dry. Okay, so save the respiratory secretion load for when they can't tolerate those conservative measures. And then finally, breathlessness. So, of course, again, the cause of breathlessness is important. If they're hypoxic, palliative oxygen is something we give quite commonly. We don't generally rush with like non-rebreathe or really, really high flows, but nasal specs, a venturi face mask, if they are comfortable with it, is quite common. And many patients will go home if they would like to have their death at home with home oxygen and nasal prongs. If the breathlessness is related to pain, somebody is breathing sort of rapidly but shallowly, opiates are quite good. And if it's due to agitation, then benzodiazepines can be quite good. Okay, last two questions. Sorry, we're going to run over a little bit. Have a look at this one. Take your time, because this is a long stem. Okay, so that is a long time. I hope I'm going to give you a bit more time actually, because that's a really long one. Okay, have a go. Hopefully that's enough time. Okay, let's have a look. Okay, so most of you are I've gone for option A, a few of you for option B, and a few for option E. Okay, right. Let's go through this so we're all clear. So, oops. So we'll just do some broad concepts first, and then we'll go through the vignette. Okay. So if we just read the vignettes, this is about a regime for her syringe pump. Okay, and she's already on some medications, morphine and cyclizine. Okay, and then it tells you a little bit about their usage. So when it comes to opiate analgesia, the first thing you need to recognize is the total dose, both regular and breakthrough, are important for calculating your requirements. Okay, now there's no hard and fast rule, but in general, if somebody is using that breakthrough, 3, 4, 5 times in a day, um, that is an opportunity for you to calculate their opiate requirements. And when you do that, you combine regular and breakthrough. And then what you do is that total is going to be the new regular dose in 24 hours. And then you give additional for the breakthrough. Okay. And in general, we prescribe anywhere from 1/6 to 1/10 of the total usage as the breakthrough. Okay. So I'm just going to reiterate that. So you might find a patient at any given moment in time, they're using regular and they're using breakthrough too often, and you want to calculate the new regimen for them. So you combine, you get the total dose, regular plus breakthrough. That is your new regular dose. And then on top of that, you prescribe 1/6 to 1/10 of that new regular dose. Okay, hopefully that's clear. So now we can go to the question. So she's on oral morphine sulfate modified release 30 milligrams twice daily. So she's getting a total of 60 milligrams from her regular dose at this point. She's also used 3 doses of her Oromorph in the last. Okay, so the new regular dose is going to be the total of the old regular plus the old breakthrough, which is 90 milligrams. But remember that in this question, we're talking about a syringe pump. Okay, and a syringe driver, the route of administration is subcutaneous. Okay, and the difference in bioavailability between oral morphine and subcutaneous morphine is 2 to 1. So whatever your total oral morphine dose, which say, okay, so regular plus breakthrough, that has to be divided by 2 to give you the new regular subcutaneous dose. And with the syringe driver, this is going to be 45 milligrams in 24 hours. And so it's going to be going at a sort of a continuous level of, just under 2 milligrams per hour. So that's going to be the regular dose. You then calculate 1/6 to 1/10 of the new regular dose. So that will fall somewhere between 4.5 to 7.5 milligrams of subcutaneous morphine, or you could argue 9 to 15 milligrams of oral morphine. Okay, and that's what you're going to give on top of the new regular dose. And just the final piece is they're on PRN intramuscular cyclizine up to 3 times a day, and she's not been using the cyclizine in the last 24 hours. Okay, so that's important because it tells you you don't need to put it as a regular drug. Keep it PRN. So now we can go to the answers, and option B is correct. And the reason is because they've got the new regular and breakthrough doses correct. Okay, so subcut morphine 45 milligrams in 24 hours over via syringe pump, and then 5 milligrams top up or breakthrough up to 2 hourly. And both of those are subcutaneous, and then PRN subcutaneous cyclizine. Okay. Hopefully that is now clear. And this is the last question, guys. Thank you for those who have stayed. I know we've run over a little bit. Again, very long vignette, so I will give you a good amount of time. Okay, Take your time, think. This is like very likely to happen at some point in your FY1 on general medicine. So take this one seriously. You almost definitely have to make such a decision. Okay. Emily, could you pop up the answer, the results of the poll, or put the poll up? I didn't actually see that one. Okay. So let's see. So yes, 50% of you have gone for E, great, and then the rest of you are split. Okay, let's go through this. So the question is about, an acute clinical scenario, and asking you what will you do. Okay, so this is one of those questions where you have to read the answer options because there's no other way you can answer it. Okay, because it depends what the answer options are. So the main parts of this vignette. Okay, we've got a 70-year-old man, and he's very unwell, and his baseline is not good. He's got community-acquired pneumonia, his severe end-stage COPD. Okay, so he's almost guaranteed not to be accepted into medical HDU and ITU just with that alone. And definitely because he's now got a DNA CPR in place, and his ceiling of care is ward level. Okay, so he's staying on the ward. He's not going to enhanced care. He's not going to a high dependency unit. He's not going to intensive care. He is very unwell. Okay, he's on day 6 of a 7-day course of IV antibiotics. His bloods are still bad. He's still symptomatic, and to be fair, his oxygen requirement at this point is actually not bad. With someone who is severe end-stage COPD, the target is going to be 88 to 92%, and 2 liters of nasal specs is a very gentle amount of oxygen. Okay, you get called because you become acutely hypoxic. Okay, and when you look, the new SAT's 74% on the same oxygen. He's tachypneic at 40, and he's tachycardic at 110. Okay, so a number of things could have happened in this individual, but the most likely is going to be either one of pneumothorax or pulmonary embolus. Okay, both of those things cause acute hypoxia. I would be surprised. I would lean towards pulmonary embolus for someone who has, very, very unwell, difficult infection. He has got lots of severe COPD, likely therefore quite bullous, and so there is certainly a chance he could have had a pneumothorax, but I would lean towards pulmonary embolism at this point. And he looks panicked. Okay, this is really not just distressing for the patient, but it can be distressing for you guys when you become junior doctors as well. Okay, he's gasping for breath. So this is one of those where he's hypoxic, so he's breathless for that reason, but he's also clearly agitated or distressed. And this is going to make everything worse. His heart rate worse, respirate worse, his breathing is going to become disorganized, and he's likely to become more hypoxic. And there's also evidence of cyanosis. Okay, so let's go through each of the answers and say why they are correct or wrong. Okay, so option A, put out an arrest call. We know he's got a DNA CPR, so this isn't the answer. Easy. Option B, needle thoracentesis. So this is for the differential of pneumothorax. The question you have to ask yourself though is, in this patient with severe end-stage COPD, refractory community-acquired pneumonia with a ward-based ceiling of care, is an invasive procedure like thoracentesis plus or minus a chest drain really in this gentleman's best interest, given the severe end-stage COPD and refractory infection? Probably not. Number 3, intramuscular haloperidol. Okay, you might think that's a reasonable option. They're agitated, but we know in this case, actually they are frankly tachypneic because of hypoxia, and that will cause distress. But the way you treat that is by treating the breathlessness, not the agitation itself. Option D, arterial blood gas. Now, it's a good thought in general for these patients with COPD. There's evidence of cyanosis, but really what you're doing with an arterial blood gas is confirming arterial hypercarbia. And the reason you want to confirm that is because your intervention is going to be non-invasive ventilation in the first instance. But we know this person is for a ward-based ceiling of care. Non-invasive ventilation immediately puts someone into these sort of enhanced care or high dependency unit settings. So we don't generally do these on wards. The only exception is on respiratory wards for some patients with other types of hypoventilatory disorders. But for somebody with an active infection and severe COPD, this isn't something we would do on a ward. We would want these in a monitored bed. And so what you're left with is administer high flow oxygen through a non-rebreather mask, okay? And out of these options, I would agree that this is the most appropriate, okay? And what you're doing in this case is palliative oxygen, okay? He's hypoxic, he's become breathless, and the breathlessness is causing some agitation, okay? Now, in general, non-rebreather masks, I'll be honest, when I was in final year of med school, I thought it would be much more common, when you see people who are acutely unwell. But you can achieve very high fractions of inspired oxygen and flow rates with a Venturi mask. You can go 10 liters a minute, get 60% FiO2, and for most indications, that is going to provide enough oxygen in the first instance. And so a non-rebreather mask practically is actually quite rarely the first thing you give. The only setting where it's reasonably common is in A&E, where you may not know the diagnosis, you may have no sort of results to go on, and so you treat empirically just based on symptoms, and then you can always titrate down, okay? And in this instance, you can do the same. Start with a non-rebreathe and then titrate it down, okay? So hopefully that analysis makes sense, and I can guarantee all of you will have to see a patient like this, and then you can do the right thing for them and make sure that they're comfortable. Okay, and that's all of the 8 SBAs we're going to go through today. We've run over about 10 minutes. I hope